Thank you, Ramsey. It's a pleasure to be with you today and to impart a little bit of information that I have. So the question, as I understand it, is about cure rates with low-grade serous ovarian cancer.
Yes.
You know, low-grade serous ovarian cancer was only described in 2004 when our pathologists at MD Anderson took the three-tier grading system for serous carcinoma or serous cancer and changed it to a two-tier or a binary grading system. So because of that, we only have really data that would go back as far as maybe 15 years, give or take. So we don't have very, I would say, exclusive or very clear data about the cure rates per stage. But here's what I would say. Certainly for stage 1, low-grade serous carcinoma, which is actually a very uncommon stage, probably only 5 to 10% of women with this rare subtype are going to be diagnosed with stage 1. We think the cure rate is going to be very high, though. I would estimate right now it would be in the 90% range. But again, we don't have very specific data yet. For stage 2, 3, and 4, I would say let's talk about stage 3 and 4. We recently reported a study, and again, it's very early because the key is to really have long enough follow-up on women with this rare subtype to really have a very clear indication of cure rates. But it looks like in stage 3 and 4, with the modern types of treatment that we are now using, the cure rate could be as high as 50%. It may be, but again, it will take some time to know that. It could certainly start to degrade and go down from the 50%. But right now, it's about 50%. For stage 2, I think, and again, that's an uncommon stage, maybe 10% at most. I think the cure rate could be 70%, as high as 70%. So, the higher the stage, the cure rate starts to go down. But I think with modern treatment, we're hoping that these cure rates of around 50% will hold. But it will take a few more years for us to really know that. So as I understand the question, you're saying that she actually does have a demonstration of disease progression while she's on letrozole. So given that fact, we would certainly recommend a change in treatment. The first thing that would be considered would be, is there any role for secondary cytoreductive surgery? That's still a controversial issue, and I think most gynecologic oncologists are going to be very selective about for whom they recommend surgery. But right now, I think the consensus is that if a woman has either one dominant mass or maybe a couple of areas, then she may be a good candidate for surgery. On the other hand, if there are, let's say, scattered small implants within the abdomen, or sometimes even in the chest, then surgery most likely would not be recommended. So that's the first question is there a role in this particular woman for secondary cytoreductive surgery? Secondly, then, definitely whether she has surgery or not, systemic therapy would be recommended. It's important to emphasize that there's no standard sequencing of treatments for recurrence. So the good news is we have many, many different options for treatment, many more than we did even a few years ago. But as I say, we don't really yet have a recipe for going to A to B to C to D. So I try, when I see a patient with a new recurrence, I tried to explain what some of the options are. There are a number of chemotherapy options, a platinum-based chemotherapy, weekly Taxol, gemcitabine, et cetera. Bevacizumab or Avastin is an anti-angiogenic that's frequently combined with chemotherapy. That's can be effective in some women who have recurrent low-grade serous carcinoma. There are other endocrine or hormonal options other than letrozole that have different mechanisms of action. So fulvestrant and leuprolide are two injectable endocrine drugs. Tamoxifen is another oral drug. And there are some new drugs under development in the endocrine therapy area that are of interest. And then, of course, there are targeted agents. There are MEK inhibitors like trametinib. There are BRAF inhibitors for women whose tumors have a BRAF mutation. And I would add at this point, we always recommend for women with low-grade serous carcinoma, but really almost for any ovarian cancer, that at the time they're diagnosed, they should have molecular testing or what's called somatic tumor testing of the tumor tissue to look for these mutations, because there are a number of drugs out there that have been developed by pharmaceuticals that can be utilized. So MEK inhibitors like trametinib would be options. And then finally, clinical trials. So there are clinical trials. Right now, there's a clinical trial being conducted by Verastem with a RAF MEK inhibitor in combination with a FAK inhibitor. Right now, women who are eligible for that trial must have, their tumor must include a KRAS mutation, but that trial is open. We just completed a trial with fulvestrant and what's called a CDK4/6 inhibitor that has been FDA approved for breast cancer and looks like it increases the effectiveness of the endocrine agent. So there are several options. And then when I discuss these with the patient, what I try to do is as much as I can individualize it and at least say, you can't say there is one best option, but you can try to prioritize somewhat and say maybe these two options would be what I would consider first, or three options in that way. But we can't be totally, I can't totally say you need to do X, Y, or Z. But that's a little bit about kind of what therapeutic options are available for recurrence. But again, to summarize, if somebody has a disease progression on letrozole, first consider whether surgery is an option or not based on the specific features. And then secondly, selecting a systemic treatment. Well, of course, any of these treatments have potential side effects. We are not at MD Anderson right now participating in that Verastem trial, although we hope to be able to join it in the not too distant future. So I don't have any personal experience. However, I am familiar a little bit with some of the data from the trial. We just met with Verastem. I would say based on what we're seeing currently, the side effects with the Verastem drug and defactinib may be somewhat better than than we've observed with trametinib, which is the drug that's not FDA approved, but it's on the NCCN compendium. So most women are able to have it authorized by their insurance, and it has been used pretty extensively over the last few years. So I think the good news is that combination of defactinib and the Verastem drug actually may be a little better, but that's not to say that some women will not have side effects in terms of skin rash, GI side effects, fatigue, et cetera, et cetera. But that, without having participated in the trial and knowing all of the details about the side effects. That's about all I could say right now, if that helps at all. I would say in general, long-term effects are not a major problem as far as we know. You know, chemotherapy drugs we've known for many, many years. Some of them, not all, certainly not all, can be associated with the development, for instance, of leukemia later on. We know that fertility may be in young women may be affected by some of the treatments. But I think I would also say it's a little too early to know if we're going to start to see any long-term effects with the MEK inhibitors or the Veristem drug. I would say right now there's nothing that I'm seeing that would portend any major long-term effects. But again, I have to say we need more time.
Okay, thank you very much. Thank you.
It's mainly the acute side effects, obviously, that during the treatments. But
yes,
if you stop the drug, most of those side effects are going to abate and dissipate. Letrozole has turned out to be a really good drug for low-grade serous carcinoma in general. But yes, it is true that many times it will be effective for a period of time and then stop being effective, and somehow the cells become resistant to letrozole. I have a few patients. Again, it's early and we haven't used it that long, but I'd say I have some patients who've been on it for like 15 years or so, number one. You mentioned the issue of stable disease, because I think, the common belief is that unless the tumor shrinks, the drug is not effective. And that's not really true, particularly with low-grade serous. Even if it remains stable and it's not growing and a patient is asymptomatic, we consider that to be a good thing. And so we would continue the drug, and that would be true of most drugs. Some drugs have a limitation. Letrozole or the other drugs, the other aromatase inhibitors, don't have an absolute limitation. Of course, side effects may play a role in that. Right now, the recommendation, because we just don't have any different information yet, the consensus among experts is that if somebody is started on letrozole and the disease is either stable or is responding, and as long as they're not having significant side effects, the recommendation is to take it indefinitely right now. And that's like potentially for the rest of their life, as long as it's effective. I think over time, as time goes on, that may be revised. Maybe 10 years is enough. Maybe longer. We just don't know right now. But we do have already a few patients who've been on the drug for as long as about 15 years and are still doing well. But many women do have side effects of various degrees, and that can be an issue. It's not a drug that's completely free of side effects by any means. Well, we don't. So CT scans, really all they tell you is size. They cannot tell you what's going on within those tumor implants. There could be necrosis, right? Dead cells, could be scar tissue, and not cancer cells. So all it really tells you is size. And of course, what we're looking for there is the lack of increase in size, because as long as we don't see a significant increase, and I'm not talking about a millimeter here or there, I'm talking about at least a 20% or more increase in the size, then that would be an indication that maybe the tumor cells within those implants are growing. But yeah, it doesn't really tell us at this point. There are a number of investigations, I would say, particularly in the radiology sphere, looking at various substances that can be used for imaging that may at some point in the future help us understand a lot better what these implants actually are made out of, and so unless you remove them surgically and analyze them microscopically, you don't really know.
Right.
But that could change over time, and we may be a lot better at knowing what it represents, scar or tumor cells or necrosis, than we are right now. Well, we just recently had a consensus conference, and Dr. Grisham was part of that, as well as about 20 other people. Unfortunately, there is no one imaging modality that we use. It's PET CT scans, MRIs. In general, I think most of us believe that MRIs may not be quite as good as either CTs or PET CTs. So yeah, I know people are concerned about the cumulative radiation with CT scans, although practically speaking, that has not turned out to be much of a problem. But I think right now there's not one best imaging. Most of us routinely do use CT scans. I have some anecdotal stories about some oncologists who just monitored women with low-grade serous carcinoma with CA-125 only. And that's not a good thing, because some of the patients have developed recurrence and there was a delay in the diagnosis because their CA-125 was not a good marker. And it's not a good marker for probably around at least 20% of women who have a low-grade serous carcinoma. So you really have to combine CA-125 with some type of imaging. But unfortunately, I don't think we can tell you that there is one best imaging modality for that. Well, I'm not sure I can give you a very good answer to this. First of all, as long as her disease is stable or better, or maybe she has no evidence of disease, that's a good thing. Immunotherapy has been disappointing in most subtypes of ovarian cancer. High-grade serous hasn't been really studied at all in low-grade serous. It's been studied in high-grade serous, and it's been disappointing. But the one subtype in which immunotherapy looks very promising, and there are a number of trials, is in clear cell. So I think the fact that she's on immunotherapy right now and doing well is great. I can't really answer the question about how long she should remain on it. I think that's something she'll have to discuss with her physician. I think as long as she's tolerating it well, they would continue, not indefinitely though. So at some point, particularly if the disease is if there's no evidence of disease on imaging and her CA-125 is normal, at some point they may stop. But that's not really, without knowing a lot more, that's not really a question I can answer. But she's definitely on the right therapy in the sense that immunotherapy has been, it looks like it's very effective. Before we had immunotherapy, clear cell, we did not do very well with clear cell. So it's really been a game changer for that disease to to a large degree, but that's probably about the best answer I can give you. So we do see patients who have, this is not that uncommon, where we're seeing a rise in CA-125. And again, when we talk about a rise, we're not talking about a few points here or there, but a doubling, even a doubling within the normal range can sometimes be significant. And certainly she's had more than a doubling of her CA-125. I'm hearing that her scan is showing no evidence of tumor progression or growth. In a situation like that, first of all, there are other causes for rise in CA-125. Many times we have no idea what is causing it. Effusions, a patient can have stable disease if she has ascites or a pleural effusion, fluid around the lungs. Even if the disease is stable, sometimes we can see that artificially elevate the CA-125. But I would say this, in a situation like this where the scans are stable and her CA-125 has risen significantly, that would be an indication for a PET CT scan to see if that is confirming, if she in fact is having CT scans. If she's having PET CT scans already and they're remaining stable and she's asymptomatic, not having any increased symptoms, then I would probably hold tight and continue. But if she's being monitored with CT scans, I think this would be an indication for a PET CT scan. Well, yeah, I think supplements, for the most part, a lot of these supplements, including very common, vitamin C or whatever, we don't really have good information about what they do to CA-125. So anecdotally, again, I had a recent patient who started Ozempic, the drug for diabetes that many people are using for weight loss. Her CA-125 like quadrupled. It really zoomed way up, and we were very concerned she had disease progression. Her scan did not change, and she stopped the Ozempic, and now her CA-125 is back to baseline. So yes, I do think we just don't know a lot about a lot of these supplements, and so sure, that's possible that's occurring as well. Infection, all kinds of COVID or urinary tract infections, any type of infection can cause a rise in CA-125 also. But again, I come back, if it's over a long period of time and there's not an explanation, then a PET CT scan may be indicated. But again, I would certainly discuss the supplements with a pharmacist or an integrative medicine specialist to see if they have any additional information about the effect on CA-125. So yes, in today's world, I would say, if there are, I think we very commonly, not always, but very commonly use what we call maintenance therapy, just like we use letrozole for low-grade serous carcinoma. In high-grade serous carcinoma, the most common subtype, very frequently, we do recommend some type of maintenance therapy following completion of primary chemotherapy. And that can take many different forms. So if women have a BRCA mutation, a germline mutation, or even if they have a BRCA mutation in their tumor, what's called a somatic mutation, it would generally be recommended that following completion of chemotherapy, they go on what's called a PARP inhibitor. which has something to do with the DNA repair of the tumor. The other maintenance therapy that's used in women who don't have, particularly in women who don't have a BRCA mutation or don't have what's called HRD, there's a test for HRD, then not uncommonly bevacizumab or Avastin may be used as a maintenance for a period of a year or a little bit longer than a year. And the PARP inhibitor generally would be given for 2 years following completion of chemotherapy. So those are two examples of maintenance therapy that may be used. And also there could be clinical trials that are studying some type of maintenance therapy as well. But the fact that you're doing great 3 years after completing chemotherapy is a very good sign. But if you were diagnosed today, not all physicians, but many oncologists would be most likely recommending some form of maintenance therapy if you had stage 3 or 4 disease at diagnosis. Yes. Well, so for stage 2, there's not a consensus, and there's the recommendations are mainly for stage 3 and 4. So that's likely why you were not recommended to receive any maintenance therapy, because stage 2 obviously has a somewhat better prognosis with high-grade serous carcinoma. So that makes sense to me. So calcifications, the medical term for those is psammoma bodies. We know from many years of study that the higher the grade of the serous cancer or serous carcinoma, the less likely you are to see these calcifications or psammoma bodies. So we see them in all types of serous carcinoma, high-grade serous and low-grade serous, and even borderline tumors. And so you see more of these psammoma bodies or calcifications with borderline tumors and low-grade serous carcinomas than you do in high-grade. We don't understand why they're there and what causes them, what's the pathogenesis, why do they develop? But we do know that they're observed microscopically, and they're certainly, you can see them on imaging. We initially thought, let's say for patients with women with low-grade serous cancer, if we saw calcifications on imaging studies, serial imaging studies, and we began to see that those calcifications actually increased over time, that was a good sign, that it might mean that the tumor cells were somehow becoming calcified, and that was good. But our radiology colleagues have done some studies with this, and they're not so sure that it means anything. It may, even if they become less, that the patient may also be doing very well. So we don't, again, completely understand the sequence of how these calcifications react over time either, whether they decrease or they increase. But the calcifications are not tumor cells. They are there along with tumor cells. But again, we just know we observe them. We just don't know what they mean. We conducted one study, and it's very, very preliminary data, but it looked like in that one study that women who had very extensive psammoma bodies or calcifications at the time of diagnosis compared to kind of what the baseline would be for most other women. And again, this wasn't quantified very well. The more psammoma bodies calcifications, possibly the better the prognosis overall. And so is it possible that if you have more of those calcifications in the tumor at the time of diagnosis, it could be associated with a better prognosis, but we need a lot further study on that to know if that's real or not. So in terms of CA-125, yes, there are some patients whose CA-125 never decreases into the normal range, but that information you have to combine with what's going on. It's not just the CA-125. So are her scans clear or not? Is she on treatment or not? But what I can say without knowing a lot more detail on her particular case is, yes, there are some patients whose CA-125 may hover above the normal range. But of course, if somebody still has disease, then that would be the reason why it's not in a normal range. In terms of the question, the part of the question about the fatigue, no, that doesn't mean that that necessarily that the fatigue is associated with persistent cancer. It may well, in fact, it usually is a result of the treatments. And what I'm hearing also in her question is, what if somebody's not tolerating treatments very well? Well, that's part of the art of medicine. The physician, if somebody has significant side effects on any medication, they may need to go off that medication and it may need to be changed, even if it's benefiting the tumor. If they are having such poor quality of life that they can't function, then you may have to change the treatment. That's true. We see that a lot, for instance, with trametinib. We can see it even with letrozole, although rarely, and I can talk more about that later. But we do see that with a lot of different treatments, that in some women, the side effects are severe. And even if they're benefiting from a tumor standpoint, the treatment needs to be discontinued and they need to go on to a different treatment. You may have to remind me about some of those questions. First of all, databases. The French have a national database for rare ovarian cancers. There is no such database in the United States right now. At MD Anderson, we do have a rare tumor program, and there are databases for some of our rare tumors. So for low-grade serous and borderline tumors, we have a database that includes about 700 patients. There's also a database for neuroendocrine carcinomas of the cervix. But there is no such national database in the US right now. I am currently working with an international consortium for low-grade serous carcinoma, and we hope to develop an international database for women who have low-grade serous carcinoma. I also can tell you that that OCRA, the Ovarian Cancer Research Alliance, is right now in discussions about developing a national database for rare ovarian cancers. Okay, so she has seromucinous. Seromucinous is an exquisitely rare tumor. I would say there are no experts in seromucinous, and there are no experts because it is such a rare entity. We know that if it is diagnosed in stage 1, and she said she did not receive any recommendation from her physician for treatment, that would be the standard recommendation: no observation and no further treatment following surgery. But we also know that a small percentage of women with this type, even if it's stage 1, may develop recurrence. We really know very, very little about the standard management of seromucinous because it is so rare. She was also asking about pathology opinions. So, for instance, at MD Anderson, when we see a new patient with any type of malignancy, including rare ovarian cancers, we almost always want to have a pathology review because that's so important in making sure that we confirm the diagnosis and agree with it. And in about 15% of cases, so not a high percentage, but in 15% of cases, we have a major disagreement with the original pathologist at the institution where the patient underwent her surgery. And that major disagreement is reflected in different recommendations. I just had a patient from a very well-respected university hospital who came to see me, and we're changing the diagnosis based on what was diagnosed. So this does occur. I think there are expert gynecologic pathologists, and I think if there's any question, particularly related to a rare ovarian cancer, it's never a bad idea, even if you're not seeking a second opinion on the clinical management, it's never a bad idea to request a second opinion on the pathology at, MD Anderson, Memorial Sloan Kettering, somewhere like that, to make absolutely certain that you're getting the right diagnosis. Yes, well, Lynch syndrome, which is primarily a genetic syndrome and can be diagnosed based on genetic testing as well as some tumor testing, is related primarily to colorectal cancer and polyps, pre-invasive polyps. But we also know that in Lynch syndrome, there is some association with ovarian cancer in general, not usually low-grade serous, usually other types. And that association is in the range of about 11% of women who have Lynch syndrome may at some point in their lifetime develop an ovarian cancer or endometrial cancer. So there is that association, but that information is the information that's needed is a combination of genetic testing with a counselor and somatic tumor testing, if that answers your question. So there was an NCI match trial that included one of the arms in that trial for women and I think men who had a BRAF V600E mutation was the combination of those two drugs, dabrafenib and trametinib. And the response rate in that trial was very high. These were patients who had recurrence. Yes, that is now an FDA-approved treatment for patients who have the V600E BRAF mutation. I am currently treating a couple patients with that combination. And that seems to be, relatively effective. It doesn't mean that it's necessarily a cure, but it is, that's really a good recommended treatment. Some patients with that mutation may just be treated with dabrafenib or one of the other BRAF inhibitors. Some of them may be treated with trametinib alone. But I think if a patient has that in today's world, the FDA-approved combination would be the recommendation. Well, again, as I mentioned earlier, stage 1, whether it's 1A, 1B, or 1C of some type, it's very uncommon. So, if you look at the NCCN guidelines for stage 1A or B, it's observation. If you look at stage 1C, I think it's observation versus letrozole versus chemotherapy. But I think overall, the prognosis is very good, and the recurrence risk should be very low, even with 1C. And letrozole is one of the options listed, and it's a perfectly fine option. I have a few patients with stage 1C low-grade serous carcinoma on letrozole. All of them right now are doing very well. None of them have had a recurrence. So that's, yeah, I think that's perfectly good treatment. Yeah, and there are also now NCCN guidelines for grade 1 endometrioid, and they're very similar to low-grade serous. There's not a direct relationship between the two. They are two completely different subtypes. Sometimes I just saw a patient recently in which her original diagnosis included both grade 1 endometrioid and low-grade serous, but there's not a direct relationship. We know that in grade 1 endometrioid also has a pretty good prognosis related to the more aggressive types of clear cell or high-grade serous. And it many times, like low-grade serous, will respond to endocrine therapy, hormonal therapies like letrozole or some of the other therapies. So chemotherapy is sometimes not even recommended for grade 1. And if it's early stage, let's say if it's a stage 1, grade 1 endometrioid, usually observation is the recommendation postoperatively. But if I'm understanding your question, there's not a direct relationship. We also know that endometrioid carcinomas can develop many times from endometriosis, which is a very common benign condition in women. Well, it is true that probably of the four major subtypes of epithelial ovarian cancer, clear cell, serous, endometrioid, and mucinous, the least amount of research has been done on endometrioid in general. If it's a grade 3 endometrioid, which yours is not, that really we think is very synonymous with high-grade serous carcinoma, and they're treated identically. But the low-grade serous are the ones where I think you can use a lot more, if you want to say creativity in terms of treatment, not just chemotherapy, but hormonal therapies. But you're right in the sense that there's not as much research in that area, but it is increasing. That one of my colleagues in Edinburgh, Scotland, is very interested in endometrioid carcinoma and is doing a lot of good work. So a couple things. One thing I would say is, yes, the number of studies have shown low-grade serous carcinoma, because it's more indolent, it's more slow growing, the cells probably aren't turning over, multiplying as quickly as in high-grade serous. It is not quite as sensitive to chemotherapy as high-grade serous, a more aggressive type. However, there's this kind of a widespread myth that's developed that it's not at all sensitive to chemotherapy, and that's not true. So there are some women who do derive a lot of benefit out of chemotherapy. So right now, for newly diagnosed patients with stage 3 or 4 disease like yourself, low-grade serous carcinoma, there's actually a clinical trial ongoing in which patients following primary surgery are randomized to either chemotherapy, like you've been receiving, followed by letrozole maintenance therapy once they completed, versus letrozole alone without prior chemotherapy. And the reason that trial is so important is we don't know which of those two options is better. Is one better than the other? Are they the same? And that trial will hopefully answer that question. So far, a little over 200 women have been enrolled in that trial. It's a trial for 450 women. So unfortunately, it's going to be about another 3 years potentially before we actually have an answer to that question. So right now, those are the two standard treatments. So it sounds like you're receiving one of the two standards, even though, yes, there's this thing out there that low grade may not be quite as sensitive, but it doesn't mean that it's not sensitive. And the results preliminarily so far is that women who receive chemotherapy followed by letrozole are generally speaking, doing pretty well. So it doesn't mean that you're at all getting substandard treatment. You're being treated in an excellent center, and I would go with it. But hopefully, once you complete chemotherapy, if you already haven't, you would then go on letrozole. A lot of great questions from people. So thank you. I appreciate it. The time spent with you. Thank you.